Hi, my name is Martin Bisson, and today the title of my presentation is a 3D visualization tool for minimally invasive discectomy assistance. I'll first introduce by putting you into context of minimally invasive surgery, then I'll present the materials and methods we use to develop our system. I'll briefly present our results, and I'll conclude by making recommendations for future work. So, first, minimally invasive surgeries, as opposed to conventional open surgeries, are done by performing small incisions through which surgical instruments and an endoscopic camera are inserted inside the body. They have several known benefits: reduced blood loss, less post-surgery pain, less recovery time, less overall treatment costs, etc. However, they bring a new set of challenges to the surgeons. Since they have to perform surgery using relatively long instruments, they lose some dexterity and tactile feedback. The visualization of the surgical site is done indirectly through a monitor and an endoscopic camera, which bring a loss of depth perception because the view they have is monocular and the lens is so close to the surgical site that there are very few depth cues available. The proximity of the lens also bring a loss of the global perception of the shape of the whole spine, and all these drawbacks result in make these surgeries very hard to learn. So that's in order to help the surgeons with those difficult surgeries. We propose an augmented reality system that presents an image integrating the regular endoscopic images with information coming from a preoperative 3D model that has been registered with those images. Therefore, the surgeon has more information than just the one coming from the normal endoscopic images. In order to realize such a system, well, in our lab, we use a 45-degree angled endoscope, which is composed of a cylinder tube containing a system of lenses that is plugged to a camera head through a circular attachment that allows a relative rotation between the tube and the camera head. This rotation helps the surgeon explore the interior of the body a little bit like you would do with a periscope. We also use the Micron Tracker tracking system, which can track in real time the position and orientation of special markers, example of which are presented here. We put one marker on the camera head and one marker on the scope tube. This allows us to do our calibration method. The first step is an offline calibration of all the parameters that is done before the surgery. These parameters include the intrinsic parameters, basically the focal length and optical center. Also the extrinsic parameters that are related to the 3D positioning of the endoscopic camera. We also calibrate distortion parameters to take into account the deformation induced by imperfect lenses, and we use rotation parameters to take into account the rotation between the tube and the camera head. However, some parameters will need to be updated during the surgery. That's why we have a second step, that is the online update of those parameters that can change during the surgery. When the surgeon moves the endoscope, the extrinsic parameters will need to be updated. That can be done by the use of the tracking system. That's what we do. In a similar manner, when the surgeon rotates the tube of the scope, we use the tracking system to take this rotation into account. Also, when the surgeon adjusts the focus or the zoom of the camera, the intrinsic parameters need to be updated. One of the members of our lab, Fantin Girard, developed a self-calibration method that we use in those cases to update the intrinsic parameters. So, as a result, in order to assess the precision of our calibration method, we use multiple views to obtain a 3D reconstruction of a known set of grid points. Then we compute the distance between those points and compare it to the accepted value. We obtain an average error of less than a millimeter, Therefore, the calibrated views of our system can be used to measure distances with millimeter accuracy. Our method also allows us to generate augmented views. The first type of view we generate is augmented reality views. In these views, the reality, which is the endoscopic images, are augmented by adding information such as reprojected 3D models or annotations such as distance measurements, etc. We also generate augmented virtuality view, in which a total virtual scene is augmented by adding real information, in this case the real endoscopic images. This allows us to show to the surgeon the anatomical structure from a virtual point of view that can be difficultly accessible by the endoscopic camera. So in conclusion, we developed a fast and simple calibration method featuring fully automatic segmentation of the calibration pattern to minimize the need for user interaction. We update the parameters of our model using the tracking system when the surgeons move around the endoscope, and a self-calibration method we developed for when the surgeon adjusts the focus and zoom. And we also develop visualization of that are augmented reality and augmented virtuality visualization. So now what needs to be done? We need to develop a framework integrating all of these steps together: the offline calibration, the online update of varying parameters, and the visualization. We need to validate this framework in an actual surgery room on an animal model in order to clinically assess the added value of our system to perform surgical tests. That's it for me. Do you have any questions?